Hello.
Hi, Devin. How are you?
I'm doing well. How are you?
Good. I think we might be on. I'm texting with Deborah about some technical stuff, so we're trying to figure it out at the moment. And if anyone else is seeing this, just bear with us as we get everyone on the panel and get ready to get started. Hi, Brian. How are you? Gloria?
I'm good.
I'm good. How are you, Erin?
Looking forward
Good.
to the panel.
Yeah.
I've listened in on the morning session. Excellent.
Yeah, it's been fantastic. And I think this is actually a really good follow-up to the conversation that we just had. So, and Gloria, you're back in your office.
I certainly am. I changed things around a little bit.
There you go. Now we're still waiting for, it's like Emily.
Equity. Health equity is one of the key themes of this summit, and I am just thrilled to have this panel of experts led by our executive in residence, Erin Byrne, sharing their thoughts on health equity. Erin is very much a leader in this space. She was formerly the head of sustainability and social impact at Novo Nordisk, so has a really strong background working with different communities on their healthcare strategies, diabetes prevention, treatment, and also she has a personal interest in healthcare, as I know. So I am just delighted that she's able to join us here today, leading the panel. I know she'll introduce the rest of the panelists, but thank you all for joining and thank you all for participating. And I'm really looking forward to a lively discussion.
Great. Well, Noah, thank you for that extremely kind introduction. And yeah, let's kick it off. So as Noah mentioned, my name is Erin Byrne. I'm an executive in residence with the Rutgers Institute for Corporate Social Innovation. And we do have a really exciting panel today with a variety of different experts that I will introduce in just a moment. But first, I wanted to take a minute to just tee up the conversation that we're about to have, as I think this topic couldn't be any more timely. And honestly, I think we couldn't have planned it any better just hearing the last conversation. I think it's a good follow-up. But here we are 2 years out from the start of the pandemic, which is just really hard for me to wrap my mind around, and I'm sure you as well. And as you all know, our world has been turned upside down, right? We've seen disparities further exposed than they were even before COVID. You take a look at healthcare, access to basic healthcare related to COVID, challenges with getting testing, vaccine access. We've seen food security and insecurity. We've seen a mental health crisis really emerge over the past few years, and that's just to name a few. And the stress on communities has also been heightened by other non-medical social determinants of health, such as virtual schooling, housing affordability, and unemployment, which I know were just topics that were just talked about a half hour ago. Yet, when we look at health equity, according to the CDC, it's achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of a social position or other socially determined circumstances. So the panel today is going to dive into that role of health equity in research, as well as the role of nonprofits, foundations, and corporations in addressing it. And just like many of our widespread national issues, the solution doesn't lie with just one stakeholder or one organization. It really does require cross-sector engagement to truly make a difference. So let's get into it. I'm going to introduce our panel. First, we have two MD, MBA students who have some research to discuss with us, Devin, Vasoya and Brian Moriarty. We have one of Rutgers' own, Dr. Gloria Bachmann. She wears many hats, so she's got a long title here. She's professor of obstetrics and gynecology at medicine. She's an associate dean for women's health, co-director of the Women's Health Institute, medical director of the Proud Gender Center of New Jersey, medical director of the New Jersey Commission on Women's Reentry. And then we have Emily Yu, executive director of the Build Health Challenge and managing director of partnerships at the Beaumont Foundation. So thank you all so much for joining and all the prep work that went into this discussion. But Dr. Bachmann, if you don't mind, I'm going to start with you. I just read the health equity definition from the CDC, but if you can expand on it and just enlighten us about why it's important and how are we seeing it play out in our everyday lives?
Well, to begin, I think that when we talk about health equity, what we're talking about is decreasing morbidity, mortality among all humans. When we talk about health inequity, that means we're increasing the morbidity and mortality. And from my perspective as a practicing clinician, I see three reasons why there is health inequity in our system. And the first is not only lack of insurance, because we all talk about lack of insurance, and obviously that's a huge barrier, but insurance not always paying for services. And I'm sure all of you have been involved with a case where they won't pay for a test that you had, or they won't pre-cert a test. So it's not only the insurance, but it's insurance paying for preventive health measures, for intervention health measures that I see as a clinician all the time where we're going through pre-certification battles. You already mentioned it, but social determinants of health play an enormous role in many of the individuals who I see who can't get to the office, that they have young children at home, or there's transportation issues, or they just don't understand why they have to come in when it's such a burden and they're waiting 3 hours to be seen, because our healthcare system, there's certainly, it's not a smooth type of transition from getting into the waiting area to seeing your clinician, be it a physician, being a nurse practitioner, or a nurse midwife. So the social determinants of health are also. And the other is that there are barriers. So the first is the insurance, the second is the social determinants, and the third is the barriers to optimal health. And let me just bring up two. The first is language, that if you go to a foreign country and your clinicians are speaking another language, or the intricacies of the language, you may not be able to explain exactly what the problems are. And the other is if you belong to a sexual and gender minority. For instance, many of our trans individuals, transgender men, transgender women, have suboptimal care because the healthcare team is not the optimal healthcare team for them when they access healthcare. So therefore, they're reluctant to go into a clinician's office because they're going to be getting horrific care. They're not going to be heard. And we see this also with many of the issues with maternal mortality, where a mom may say, I have a headache, and it's just, you know what, you're stressed, rather than that barrier being knocked down and saying, well, how long have you had it? Is this preeclampsia? So those were the three things that I see as a practicing clinician.
Yeah, that is really enlightening. I think it leads us right into some of the research that we're about to hear from Brian and Devin, who've really been looking into how health equity plays a role in some of the clinical outcomes that they are looking at. They have two studies to summarize for us. One is the racial and socioeconomic impact on age at procedure for hip and knee replacements, and the other is urban and rural outcomes and disparities. Brian, if we can start with you, and I think some of the things that Dr. Bachmann just mentioned around those three areas really are something that you mentioned to me earlier about the things that were impacting and what you were finding in your research. So if we can just start with you and summarize your findings, and then we'll go to Devin.
Yeah, thank you so much for having me on this panel today. It's really such a pleasure to be here. I really do want to echo a lot of what Dr. Bachmann just said. Devin and I are both medical students at Rutgers, New Jersey Medical School, where the hospital that we spend the majority of our time at is University Hospital here in Newark, New Jersey. So health inequity, social determinants of health are something that we unfortunately see every day and are things that we are very passionate about, which is why we decided to get involved with this research here. I myself am interested in applying into orthopedic surgery. So I wanted to find how I could identify health disparities within orthopedic surgery, because like we discussed, Erin, you can't solve a problem if you don't know what the problem is. And most important, you really have to define specifically what the problem is. We live in a society, and especially a healthcare system, of very finite resources. So identifying problems that are worse than others so that we can focus on those, divert finite resources to where they need to be, I think is a very important first step, which is where we are in the research process right now. My research specifically focuses on a disease that many of us are likely familiar with, either within our own lives or within our friends or loved ones, which is osteoarthritis. Osteoarthritis affects over 30 million Americans. And one of the things about osteoarthritis is it's an extremely activity limiting disease. So the current estimate is that osteoarthritis causes approximately $17 billion annually in lost wages because individuals are unable to go to work as a result of the pain of their osteoarthritis. So what my study looked at is how can we identify late stage osteoarthritis and how it's affecting racial and ethnic groups unequally. So what we chose to look at was knee and hip replacements, which is the sign of end stage disease within osteoarthritis. And what we found is that racial minorities, specifically African-American and Hispanic patients, undergo joint replacements at ages significantly younger than their Caucasian counterparts. What does this mean? Well, to give you an example, within hip replacements, the average age of replacement for a Caucasian individual is in their late 60s, but for a African-American individual is in their early 60s. If you use the Medicare age of retirement, you could easily see how African-American individuals are more likely to need to undergo knee replacement at a time during their salary producing years, which could be a huge impedance on their family, the people that they support. These are not procedures that you bounce back from quickly. You can expect to be in recovery for long periods of time. So needing to undergo these procedures at younger ages, again, going back to what Dr. Bachmann said, focusing on morbidity is very, very important. What is the effect on the quality of life of these individuals? And needing to undergo these procedures at younger ages, which we found for both hip and knee replacements, I think does really shine some light into how difficult it can be for our racial minority groups when it comes to orthopedic conditions such as osteoarthritis.
Perfect. Thank you so much for that, and look forward to continuing to have you in the conversation. Devin, I'm going to hand it over to you if you can kind of summarize from your perspective as well.
Sure. Thank you, Erin. So the study I looked at involves the field of cardiology, and it's really relevant to Americans because heart disease is the #1 killer for Americans. About 25% of all deaths are due to cardiovascular disease. And every year, about 800,000 patients have a heart attack, which is a shocking number. It's astronomical, considering there are approximately 350 million people in America. So one out of 300 pretty much have a heart attack every year. And when you dive a little deeper, these heart attacks are classified into different ways, but the worst kind is called a STEMI. And what that means is you have blood vessels feeding the heart, and there's a complete blockage of blood flow there. So as you can imagine, if no blood can get past the blockage, the downstream heart muscle is going to die. And this really a horrible situation because now it opens up patients to having life-threatening arrhythmias, just irreversible damage to the heart. And so really the goal in treatment here is to, like the mantra is, time is heart. You want to fix the patient's blockage as soon as possible. And so what the study I was working on is looking at is how are the differences in death rates when comparing urban patients and rural patients. And so the logic here is that if you live in an urban area with over 1 million people around you, you likely have huge hospital systems near you and you have access to care. And so since we were saying time is heart, if you have access to healthcare, you'll be able to undergo these procedures to fix the blockage faster, right? As opposed to living in an urban environment, or sorry, a rural environment where oftentimes you're like 3 hours away from the nearest hospital that can treat your heart attack. And so if you've been having this lack of blood flow for like 3 hours, I mean, you can see really poor outcomes in terms of death and then lengths of stay in the hospital. And so this has implications in the field of like access to healthcare, really. And what we found was surprising. So you would think that because patients who live further away from hospitals in rural areas, you would think that they would die more frequently. But in fact, we found the opposite. In fact, if you are living in an urban area and have a myocardial infarction, you are more likely to die in hospital than a rural patient. And it was pretty significant. The death rate for an urban center was 2.7%, as opposed to a rural center, which was 2.2%. And then furthermore, if you were to stay in the hospital after you got treated for your heart attack, your length of stay in an urban hospital was also longer at 3.5 days compared to 3 days in a rural center. So this just shows that our initial thought that living in a rural area would have a worse outlook on your death after a heart attack is not the case. In fact, living in an urban area is worse.
And do you have any reasons or, hypothesis on why that is, aside from just, because it sounds like you might have been hypothesizing that if you get to the hospital quicker, you'd have better outcomes?
That's a great question. So there are a few main hypotheses out there. Really, a compelling one is that for the patients living in rural areas, if you have a massive heart attack that cuts off blood flow to most of your heart, you actually won't make it to the hospital alive. So you won't be captured in the data set.
Okay.
And that's really which is one of the limitations of this study. The other thing is that patients who live in urban areas also have more comorbidities. So they have worse types of high blood pressure, and they also have other vascular disorders like peripheral vascular disease. And these are all contributing factors into the whole schema of having a heart attack and the outlook that comes along with it. And another really important one is actually just a public health initiatives. Really, like, do patients know what the symptoms of a heart attack are, or who to call? How do you get to the nearest hospital? And that's really that's another big factor when it comes to this.
Yeah, absolutely. Okay, so
I'd like to add one other thing that I see all the time, and it's already been discussed, but that at some of the hospitals in rural communities, they don't have all the comprehensive services that an individual may need. And we see this all the time of transfers coming into Robert Wood Johnson University Hospital because they couldn't be cared for at the local community hospital, so that they're really not getting the immediate care that they would get if they came, for instance, here, where they have ECMO and other things that they don't have at the other sites.
Right.
And this really just goes back to the point, this takes more time to transfer the patient and things like that.
Yeah, so it's interesting because it's really, key takeaway is the location of the community that you live in has a direct correlation to some type of, health outcomes or healthcare that you're receiving. And that's just, some of the research that you're showing. So it's very interesting. And if I can go back just for a moment, just to look at, again, the racial and socioeconomic impact. I know that there is a lot of data indicating how, racial and ethnic minority groups throughout the U.S. have experienced higher rates of illness and death across, a variety of different types of conditions. I know that the WHO has even cited that 94% of all maternal deaths occur in low and middle income countries, but here in the US, we're seeing that Black mothers have a 2.5 greater mortality rate than white. So Dr. Bachmann, if you can step in, I think this is, picking up from some of Brian's research around the racial and socioeconomic status, but what are you seeing in your work specifically, as it relates to maternal mortality rates?
The data are so clear on this, Erin, and obviously everyone on this call knows that the and this was seen with very top-notch stars like Serena Williams, where oftentimes their voice is not recognized or heard. And I think that's the first thing that we're beginning to see. And that was the third point that I said with health inequities, that these barriers, that you may have the insurance, you may be able to get to the hospital, but are you believed once you get there that your symptoms are symptoms that have to be evaluated quickly, that have to be checked out, that you just can't wait and say, oh, you know, this is nothing, this headache that you have or the shortness of breath, it's just anxiety. So it's really the third point of giving optimal care to every individual, and not to have racial biases, social biases in the care of individuals. So it's a continuum of not only the access issue and having insurance and the language issues and the barriers to coming in, but once the individual is in, are they getting the appropriate care that they need? And all three of them are what's impacting our maternal health. And we are addressing it very actively through educational programs, through community outreach, through role models, that we're seeing that when an individual is really interfacing with another individual like themselves, they feel more comfortable and they're more likely to follow through on instructions. They're more likely to be heard, so that their voice is being heard and they feel that someone who understands them is hearing them.
Yeah, that's a critically important comment that you just made. And I actually want to go over to you, Emily, because I know that you and all the work that you're doing and the many hats that you wear, you are intently listening to communities and populations, diverse populations, and working to address them in a variety of different ways. So if I can just point it over to you to say, can you just tell us a little bit about the Beaumont Foundation, what you're doing there to fight health equity? I know you have two programs, the Build Challenge, but also the Health Action Alliance. So if you can just tell us a little bit about those, and then maybe what are the implications of the work that you're having on the communities?
Sure, thanks, Erin. And I'm rapidly and attentively listening to my fellow panelists, because I think the perspective I'm bringing is sort of the complement or the other side of the coin in a macro sense. So the Beaumont Foundation, and in particular the work we do with the Build Health Challenge, is really one that's community-centered and one that focuses on cross-sector collaboration, because I think all of the issues and challenges, the barriers that Dr. Bachmann mentioned, right? All of these things are things that no one sector, no one individual can address. And so what we're trying to do with De Beaumont, alongside fellow funders and fellow corporations and other public health departments, is really figure out, how can we help build capacity? How can we support communities where they are? How can we help address these root causes of chronic disease using community assets? And this framing that doesn't necessarily think about, on the one side, my fellow panelists talking about maybe interventions at the hospital. How about also complementing that with what we could do from a prevention framework? So the work sort of, if you will, De Beaumont Foundation, we're really looking at the policies and practices that really help keep systems in place that are the barriers that Dr. Bachmann mentioned, right? The language, the access, a lot of the things that have to do with not only cardiovascular disease, but when you think about diabetes, and then you take another step back, what is leading to that? And you start peeling back the layers of the onion. We sort of like to think about this analogy of, one's house. If the foundation starts having cracks in it, and that's what we liken to the social determinants of health, these root causes, things like, again, food insecurity, like you mentioned, Erin, transportation access, maternal health. If those sorts of grounding and foundational pieces start having cracks, that's when you start seeing things in the walls and the floor not becoming level and the roof starting to leak, right? And so you can patch and patch and patch all you want, but if you never address the root causes in concert with what my fellow panelists are doing and their research is showing, then these problems will continue to surface. And so that, at the end of the day, from the perspective that I bring on behalf of the communities, that's why health equity is so critically important, because if we don't look at all of these issues that are being raised by my fellow panelists and things that I shared as social determinants, right? if we don't take that health equity lens about everyone having a fair and just opportunity to achieve their best level of health, we'll always have to keep coming back to try to patch without having a resolution.
Yeah, that's a really good way to frame it. Very easy to understand as well. So thank you for that. I do want to ask you about getting a little into the Health Action Alliance. I know that one of the key focus areas that you're working towards is addressing the needs of disproportionately affected communities. And I say that, you know, with air quotes, because it is one of the very specific written focuses for you all. So I think that also just gets to some of the key things that were coming from Brian and Devin and Gloria as well around racial disparities and location, right? Cutting that down to the location that you live in, the community you live, and, you know, your ethnic and racial background. So, you know, why was this chosen as an area to focus on? And if you could just also expand a little bit further on the work that you're doing specifically.
Sure. The Health Action Alliance, in a nutshell, is a collaboration, if you will, between cross-sector partners, including the Ad Council, Business Roundtable helped form it, the National Safety Council, CDC Foundation, alongside the Beaumont Foundation and others. They came together at the beginning of the pandemic, identifying a need to align business and community health and public health more intentionally. How can we help provide and surface tools and resources that can really bring the best of both sectors together to support communities during this unprecedented pandemic? What has transpired over the last couple of years is that there are many leaders doing this work and actively shaping how business and public health can work together, but there is still a really, really long road to go, right? And so we're certainly not creating something brand new or something completely innovative, by no means. But what we think is an opportunity that the pandemic has helped to open a window on, or a door to, is this idea that we can be much more intentional on connecting these dots across sectors. So I'll just put a fine point on what my fellow panelists were mentioning. This idea that employers, and particularly for this audience that might be of interest, employers, private sector leaders, chamber members, policymakers, et cetera, really thinking about their bottom line as being integral and inextricably linked with community health. Because when you think about it, your employees and KPIs or metrics that you might measure along absenteeism, along productivity, along your supply chain, right? All of these things involve community members. All of these things involve these stakeholders needing to be at their best in order to be the most productive, not only as employees, but also as consumers, as supply chain providers, right? And so when we think about how inextricably linked health and business is, and we saw an unprecedented number of businesses shut down as a result of the pandemic as well, you know, we really think that a pandemic is not the first time that you should be picking up the phone to call one another for both sides of this, right? Both the public health departments and the businesses, just as two sectors in this grand scheme of things. So our hope is, you know, let's really reinforce and deepen those relationships with tools, resources, and information, and start talking about what's working. Let's talk about what's not working and figure out how to strengthen those relationships so that we can have better health for all.
I think that's fantastic. And that really gets to, you know, one of the questions I was going to ask you next, which is, you know, why is it important for business to tackle the issues of health equity and what's in it for them? But I think you kind of answered that already, right? And I think that's, you know, we believe that's why the Institute here exists, is because, you know, that we believe that there's a huge power in the private sector in helping address a lot of the social issues that are out there. So thank you for that. You know, I think you also just hit a little bit on cross-sector engagement and why that's so important, but you also, I just want to catch for our audience here that a lot of what you mentioned in the actors and the stakeholders that are in Health Action Alliance are a combination of public, you know, and private, right? So really coming together and looking at, you know, whether you call it public-private partnerships for advancing public health, or whether you're just looking at, you know, some type of engagement to kind of make the voice louder on the need there. Cross-sector engagement is really key, isn't it?
It is, yes. And if I could just say one more thing too, you know, a recommendation that came out of talking with representatives from both sectors was this idea of, we may have different specific metrics that we're looking at, but when you peel the onion, the layers back far enough, then there are these shared metrics along the lines of, for example, addressing absenteeism, productivity, et cetera. And so the idea of having the ability to reinforce one another's actions and support one another. So you could imagine a world in which business leaders are doubling down on this idea of community health being important for the reasons we just mentioned, and vice versa, supporting one another's policy efforts, right? Helping to make these changes sustainable in terms of whether it be paid time off or sick leave, or maybe, we saw this happen really successfully with tobacco measures and stopping, the proliferation of tobacco, where it was a complete detriment to community members and employees. So thinking about, starting with maybe the employee base, but then really understanding the concentric circles and how things like cardiovascular disease, diabetes, and things like that actually play a role. One quick example to give you, there was an employer, a major Fortune 500 employer, who actually did an assessment of their insurance and what they were paying for their plan. And because they had a pretty broad sense of coverage, they were actually supporting 20% of their payments were going towards active employees. The other 80% was covering family members and other retirees, people that were not currently working physically in their office at the time. And so when you think about community and what that means, there is a lot of alignment to be found between current employers and their base and the broader community. So I'll offer that to you. It's close.
Yeah, no, I think that's absolutely true, right? Where, anybody who's out working is part of the community, as also mentioned. And, it just makes me go back to, Devin, your point about, was it $17 billion in lost wages, right? What does that mean? That means it's a healthcare related thing. If people can't work, that's an employer thing. And then here we are, they're not able to thrive in the economy. So a lot of systematic changes that I think are probably, needed here. And I would love just to get all of your take on that. We've talked about insurance and barriers and a variety of different things, but, if you could kind of nail down or had one recommendation to a systematic change that needs to happen in the US, what would that be?
So I'll get started. One thing that I really liked from my research, which supports a lot of what Dr. Bachmann was saying and what Emily was just saying, is employees need to feel as though they are safe to take time off from work to deal with their medical issues. And that's definitely a big role that business can play in ensuring that employees have the financial stability and the reserves to take time off from work to deal with their medical issues. And that also refers to a lot of the barriers that Dr. Bachmann was referencing. One of the things I looked at in my research is how many patients allowed their disease to advance to joint failure before they got a joint replacement. And the idea is that percentage should be 0 among all groups. You should get a joint replacement before your joint completely fails. What we saw was actually significant racial disparities, especially among Hispanic patients, where they were 5% more likely to have a joint that failed upon the time of their joint replacement versus Caucasian patients. And while this is a little bit of hypothesis, there's no clear data to support this. I don't think it's difficult to abstract the fact that minority workers work in much more blue collar, high labor positions, and among jobs that likely do not offer them the opportunity to take time off from work or do not have the financial stability, the childcare to take time off from work. And unfortunately, their diseases progress to the point until they are, in my case, disabling, or in Devin's case, life-threatening before they are handled. And I think that's a great opportunity and something for us to tackle.
Thank you for that. Yeah, the system of care and paid time off is a huge one that I think our country is behind in, for sure.
I'd like to expand on that, because I think the other issue that I see all the time, and that's why I would push for healthcare coverage to include more mental health coverage, is there's a lot of denial. There's a lot of cultural denial. There's a lot of personal denial. There's a lot of, I can't be sick. I'm too strong. I'm too important to my family. I'm going to ignore the symptoms. I'm going to take an antacid, even though I have chest pain all the time when it's, heart related. So I really think that we have to address more of the individual's emotional and mental health as well, because it truly does play a major role in many of the patients who I care for, that there is this sense of, just what you were saying, Brian, that, I could deal with this pain and I'm just going to take more aspirin or whatever. But we really have to understand the thinking of that individual and why they're reluctant. And again, some of them, it is the social determinants of health, the lack of insurance, the lack of access. But for others, it actually is their own denial. When we even look at those who are morbidly overweight that come into the office, that they just can't handle it themselves. And shouldn't we be giving them the emotional and mental health support that they need? And I think that's what I would push for, more mental health services for all individuals. And you don't have to have a psychiatric illness or a diagnosis, but rather dealing with everyday issues.
Yeah. And I think, and I'm sure you would agree too, stigma, right? That goes with it, that, either that they're afraid of having some sort of a bias towards them, or like you've explained, people not believing them. But also I think there's a lot of population, and I'm speaking from some of my own family members who just say, no, I'm good. And it was just, historic thing. I don't know, ways that the older, generation was brought up, that they can just, just deal with it, right? As you mentioned. So I think that's a really, really important one. So thank you for bringing that up, Gloria.
But I also want to bring up one other thing. Mental health services are very difficult to come by. They really are. That many personal friends and family have said that for behavioral issues, for other issues, it's very difficult to get care. It's very difficult sometimes to have it paid for, et cetera, et cetera.
Yeah, so that's good. So the coverage as well as getting the services expanded. Great.
And then also, if you just look at it as through the lens of access to care, right? There's all this talk about a doctor shortage, but we actually don't see that in the Northeast and the West Coast. We're very fortunate to have a surplus of physicians. And this goes back to Dr. Bachmann's point, where a lot of rural areas don't have access to these hospitals with physicians or facilities capable of handling certain types of heart attacks. And so one of the things that has to be pushed is getting physicians out there, moving to different communities, going to the rural areas. And that's really been the push. You see this in a lot of these hospitals in the Midwest are having, they provide a lot of incentives for physicians, nurse practitioners, physician assistants to move out there because these communities are in need of healthcare.
Yeah. So Emily, I was wondering if you can jump into this point, because what I'm thinking is, what role is there from a foundation or a business standpoint to address what Devin just mentioned, and, to give better, coverage, if you will, to rural communities? And is any of the work that you've been involved in addressing that?
Yes, I don't want to speak too broadly, so if people will forgive me for generalizing a bit, but I really appreciated those points in terms of, things in actionable, tangible pieces that foundations and or businesses or even, frankly, other cross-sector leaders could try to support. From the communities that we get to work with across the country, including both rural and urban, a lot of it has to do with resourcing. I think at the heart of what people can try and take away from what we're trying to share and convey, this is really convoluted and complex. There's no one issue, whether it be the mental health issue, whether it be hip or cardiovascular, all of these things are pieces of a giant puzzle. And the puzzle is really hard to see, as a whole. And so when we're trying to sort of be additive or be supportive of things, I think one, not necessarily fail-safe, but one very important first step is really working with the community members, whether they be the patients, whether they be community members representing certain groups, really engaging with them to understand what their needs and concerns are before making a leap to necessarily even provide dollars or provide care or support, right? So working in tandem, which I think is what you heard from all of us here on the panel today, to identify root causes, whatever that may be, because it may not be evident, it may not be so obvious, as you heard, whether it be unpacking the layers of cardiovascular disease or hip joint issues, et cetera. And so when we can peel those layers of the onion back with the community members and understand what is at play, I think working and pulling levers that we as foundations, as business leaders, as policymakers in particular are well suited to pull, whether that be advocating for change or for dollars or for resources. I think those are what are not only helpful, but also sustainable. Because I think the other piece of this puzzle that we're trying to address for is not just a Band-Aid on an issue, right? Because these things are systemic in nature. So what can we do that's going to actually help in the longer term? And so I'll offer that as a couple first steps organizations can take.
Yeah, no, thank you for that. Absolutely. Keeping on this idea of systematic change, I know policy has been mentioned by you, Emily, and by a couple of you on the call. So what role does policy actually play in a lot of these issues? For anybody.
I'll pause for a moment. I'm happy to jump it back in then.
Yeah, go for it.
Yeah, I'll just briefly say for policy, wow, when we get back to health equity and really what's at the heart of everything that we've all been saying, I will just share that policy is really one of those frames that not only holds in place broken systems, right, that are perpetuating a lot of the harms that we're seeing manifest in health conditions, but it also is the on-ramp to solutions, right, that are sustainable and that can lead to significant change. I'll just offer up, a stat. The social determinants of health that we referenced, right, it's been documented up to 80% of our health is really related to those social determinants of health, those things that are not necessarily focused on an individual's DNA, right? It's not necessarily that. So that 70-30 overgeneralized, forgive me, split. So when we think about that and all the policies that affect things like the quality of food and access to food, like our transportation, education, employment, and for better or for worse, all those things fall under the umbrella of health in some way, right? Mm-hmm. And all of those things, for better or for worse, ladder up to the conditions that my fellow panelists are talking about and trying to effectively address. So unless we're starting to peel back those layers of the onion and get to the foundation of that house that we talked about, policy really is what is going to be what is one of the most effective routes. And so policy, whether it be things like policy meaning having a grocery store in places where there currently is no grocery store within 1 to 2 miles, right? Yeah. That's a policy issue. That's also a community development issue. Having transportation be accessible, that's a policy issue. Having representation, like Dr. Bachmann mentioned, having those voices at the table, that's also a policy issue, right? And businesses, foundations, hospitals, anchor institutions, let me be clear, have an outsized role when it comes to shaping and influencing the policy, both being vocal and even in their silence, I think, as we've seen recently in some major national headlines, right? So yeah. I'll just offer up to this group in particular, please, that the power that you hold as institutional leaders and anchor institutions in your communities when it relates to policy, it speaks volumes even in your silence. And so I would encourage working with community members, working and collaborating, and not alone. This is something, with your partners in your community to understand what aligns with your interest and promoting those.
Yeah, and I'll just add is, the Institute for Corporate Social Innovation truly believes that, advocating on social issues from a business perspective, it's one of the 4 pillars that this institute has, under their methodology. So firmly agree with all the points that you've mentioned. But let me offer, thank you for that, Emily. But let me offer it up also to Gloria, Devin, and Brian. Yeah.
Yeah, I wanted to also comment on what Emily just said, because what we're doing here with Erin and the Institute is revolutionary, because healthcare has really been thought of in the past, and it's a very archaic type of thinking that it's basically the clinician and the patient, and they're isolated in a vacuum. So that if someone comes in with hypertension, it's a medication, and that's the circle, and not thinking about all the other policy issues, all the other social determinants of health, all the other aspects. Can that person afford the antihypertensive, et cetera, et cetera? So I think what this panel, what we're doing is we're forward thinking. We're saying there's lots of issues involved in health and health care. And it's not just that dyad of the clinician and the patient, that it's more than that. And we have to look at it as the full circle of all the components.
Yes, it's very intertwined, right? And not always obvious to, to somebody on the outside who's not living with it and dealing with it every day, right? Absolutely. Devin and Brian, any other words on this topic?
Yeah, I mean, we already discussed the issue of paid time off from work, but I think there's another issue that's kind of along line with that, and this actually is much more prevalent in Dr. Bachmann's specialty. But think about family and medical leave in this country. Leave for new mothers in the United States is some of the worst it is anywhere in the developed world. We offer new mothers almost no leave to spend time with their children after they're born. But also I'd like to talk about leave for family members who have recently had surgical procedures. You look at the proliferation of skilled nursing facilities in this country in the last 10 years, and it's because nobody can take time off from work to take care of their loved ones after they've experienced a medical emergency or a surgery. Whereas instead, if we offered people the opportunity to take time off from work to take care of their loved ones, they wouldn't have to stay in these facilities where there's increased risk of infections and poor outcomes, and essentially just perpetuates a lot of the problems that we've seen in the first place. So offering people the opportunity to both take care of themselves and take care of their loved ones with having time off, I think is a great policy directive that I know that we are working on, but needs more work.
And I think that brings up the whole issue of home health care, that in the past, a clinician would go to the home and evaluate the patient, take care of the patient. And then it really drifted to the patient had to take the bus, take the train, take the car, walk to the clinician's office. And as Brian said, there's so much that can be done by utilizing the resources in the community, in the home.
Yeah, absolutely. Devin, anything else to add from your perspective on this topic of policy?
Thank you. So really, I think we really can't underestimate society in general in terms of their pressure they can put on policymakers. And really, it's organizations like this and panels like this that get the word out to the general population, and you really get to spread the knowledge of what is actually going on within healthcare. Like what are some of the downfalls? Because there really isn't an outlet for people to hear what's wrong with healthcare as of now. And so I think just having the public aware and putting pressure on policymakers to really get the ball rolling, make some actual high quality changes is really like the main driver for this too.
Yeah, grassroots movements, right? If you write your own representative, your constituent in their area, they're going to want to listen to you. They're going to want to get your vote. So I think that's a really powerful message too. Listen, I want to be very mindful. We do have a hard stop in just 3 minutes. We do have one question that did come up is, do you think that the COVID pandemic exacerbated reluctance for people to address their health concerns and seek treatment? So that might be our last question here, but I wanted to get your thoughts on that.
I would say absolutely, from the clinician point of view, that not only were individuals reluctant to come out of their home to go to a medical facility, but most of the medical facilities had limited access. And I know that my brother had a crisis and there was no place that he could go except to an emergency room because there were no offices open. There was no even the urgent cares open. There was nothing open. So I think it was basically on both sides that a lot of the medical facilities had not really, anticipated this type of a problem. So we're not prepared for a pandemic, and therefore we're not seeing individuals who needed help, except, emergency rooms on an emergency basis. And persons were reluctant to leave the house. There's so many that said, I'm not leaving. I don't want to become ill by being exposed to others who may have COVID.
Yeah, we also definitely have the data to support this, again, within Dr. Bachmann's realm there, but we saw a precipitous drop in the number of mammograms that were performed in the years during COVID and still in the years after. So people were afraid to go to these healthcare facilities and are not keeping up with their preventative maintenance. You also have to remember that during COVID, all elective procedures were canceled. Joint replacement is an elective procedure, regardless of how debilitating the disease is. It is not considered a medical emergency that is going to kill you. Imagine having advanced stage osteoarthritis in January or February of 2020 and having to wait a year to get a joint replacement. These are people who had to put off their entire life as a result of not being able to get that treatment.
Yeah. And then not getting help in the home most likely as well. So making every day a little bit more difficult. Yeah. Thanks for that, Brian. Well, thank you to everybody. I mean, a couple key takeaways is I think we just realized this isn't a very black and white, issue. It's very, I see this red thread going through all of these issues that we talked about today, and more, right? I think we just probably were scratching the surface, but a couple of key takeaways is really that we need to get down to the root causes of what's going on. Definitely needs to take cross-sector collaboration and engagement to be able to make a difference, and advocate from both a corporation and an individual standpoint, because as you heard today, there's plenty of policy changes that are needed in many different areas. So again, thank you to Brian, Devin, Gloria, and Emily. I truly, truly appreciate your time and your energy on this panel, and hopefully you all enjoyed it.
Thank you.
Thank you. Thank you.
Yeah, thank you so much for having us.
I just want to
Absolutely.
my thanks, and I hope you all will continue to join us in 10 minutes for the introduction to the climate justice track. Thank you again.
Bye-bye.
Thank you, everyone.